Hey, everybody. Welcome back to another episode of Pulm Peeps. Been another week or so and very excited to be back for a great additional topic. Hey, Christina, how's it going?
Hey, we're doing good today. Yeah, I'm excited as well. Today's episode is another one of our top consult series, which I think we really liked. And today we're going to be talking about pneumothorax. So I know that this can come up for a lot of people, throughout training, and definitely was a common kind of consult throughout fellowship. And I know can be very daunting for people. So we wanted to try to walk through it and help simplify things. And thankfully, Furf, you and I are joined by some experts today and have some help. So we're so excited to be joined today by Dr. Christine Argento. Christine is an associate professor of medicine at Johns Hopkins Hospital and is one of the most amazing interventional pulmonologists that I know. She's so skilled and I think is going to have a lot to offer for our listeners today. So, Christine, welcome to Pulm Peeps.
Thank you so much for having me. What an introduction. This is amazing. Thank you.
And next we have Charlie Murphy. Charlie received his medical degree from LSU School of Medicine in New Orleans and completed his internal medicine residency at the Montefiore-Einstein Internal Medicine Residency Program in New York. He is currently a Pulmonary and Critical Care Fellow at York-Presbyterian Hospital, Columbia University Medical Center, and is one of the chief fellows there. It's great to have you on Pulm Peeps, Charlie.
Good to be here. Thank you, Dave and Christina, for having me. Big fan of the pod, so it's cool to be a part of this.
Thanks so much, Charlie. And before we get into our further discussion, I just want to have our disclaimer for everyone that this podcast is not meant to be used for medical advice, and the opinions are our own, do not reflect our employers. And the cases referenced today are going to be HIPAA compliant with some details that may have been changed.
Oh, consult's coming in. All right. We have a 26-year-old man named Barry who came to the emergency department with acute onset of shortness of breath. He quickly had a chest x-ray done, and there was a right-sided pneumothorax. So they paged you as the pulmonary consultant fellow. Charlie, when you get this page, what are like the first things that go through your head? You know, you have a page, you're running around, you're going to have to see this patient. Pneumothorax comes in. What are the first things you're going to want to talk to them about and assess the patient?
Yeah, so I think, whenever you get called to see any patient, probably the most important first consideration is how sick are they? Are they stable or are they in distress or are they coding? There's obviously a huge variation. And pneumothorax, like many things we see in pulmonary critical care medicine, is life-threatening. So these patients can be at death's door when you get called, or they can be, totally asymptomatic with stable vitals. So the stability of the patient is always important, but with respect to pneumothorax, it certainly can impact how you manage them. So first is like, how stable are they? Next, you should ask yourself as you're walking to see them, do you know if this patient has any underlying lung disease? Obviously, the first thing we think of when managing a pneumothorax is placing a chest tube, but not every one of these patients needs a chest tube. And, one of the kind of branching points for when we decide whether to place one or not is whether or not there's like a quote primary spontaneous pneumothorax in somebody with no lung disease, or whether it's quote secondary in somebody who has underlying lung. People who have underlying lung disease, I would say, generally tend to have lower cardiopulmonary reserve. And so you might be willing, or I think interested in pursuing like a definitive intervention with a chest tube in them than you would in somebody who's like healthy otherwise with the primary pneumothorax. And then some of the lung diseases we think about that are associated with pneumothorax. First, I think in our population would be COPD, but then, different types of ILD, cystic lung diseases like Lamb, Langerhans, Bardet-Dubé, cystic fibrosis, and then some infections like TB and classically PJP pneumonia can lead to pneumothoraces. And then third, an important consideration is how big is a pneumothorax? Those that are smaller tend to be, more easily managed conservatively, whereas those that are bigger, more likely are to need tube. And I think the cutoffs people use can vary depending on who you talk to, but generally you'd say 3 centimeters at the apex between the visceral and the parietal pleura, or 2 centimeters between the visceral and parietal pleura at the level of the hilum are your sort of cutoffs for a large pneumo. And then last, is this the first pneumothorax or is this a recurrent pneumothorax? Because if it's a recurrent pneumothorax, then they're more likely to need some sort of definitive treatment. So I think those are the 4 main considerations when going down to see a patient with pneumothorax.
Thanks so much, Charlie. That's a great approach, kind of what factors to consider. And I think definitely kind of how we approach all of our top consult series, really kind of focusing on the clinical stability of the patient, as you mentioned. So for this patient, I know you're concerned and you get to talk to the consultants a little bit more, and we have some more information available. So I will say that this gentleman is tachypneic to his mid 20s. So tachypneic to respiratory rate of 26 to 28. He was saturating 88% on room air. So he was put on nasal cannula and is now 95% on 4 liters. He's tachycardic with a heart rate of 120, and EKG was confirming sinus tachycardia. Blood pressure was 145 over 85. We only have limited history, but he reports that he's never had anything like this before. So you quickly pull up his chest x-ray and you notice that the pneumo is 5 centimeters from the apex. So I don't know, Charlie, that could be kind of scary or concerning for anyone being the pulmonary consultant. So as you said, you told us to assess the stability, and it sounds like he's pretty unstable. And Christine, I'm sure you get a lot of pages like this on a daily basis. If you had a patient like this and you were seeing them in the ED, what would be your approach to the patient?
So this is really a common scenario, something that I see all the time. And people do really struggle with this. So I guess I think about it in terms of whether this patient is stable, more urgent, or emergent. And in this patient's case, I would probably classify them as urgent. They're certainly not stable. They're requiring oxygen. They're tachypneic. They're tachycardic. And so this wouldn't be considered a stable pneumothorax patient. Also, the size of the pneumothorax is pretty large. And so you would think that this patient needs some sort of intervention. Just as Charlie mentioned earlier, 3 centimeters of apex is really our typical cutoff to define a large pneumothorax. And so 5 centimeters. I wouldn't, however, call this patient emergent, meaning that they are relatively hemodynamically stable or stably unstable, I guess you would say. They're requiring oxygen, tachycardic, tachypneic, but they're saturating 95% on oxygen. Their heart rate is not 150, 160, and their blood pressure is definitively they're hypertensive, not hypotensive. And so I think you have some time and you don't have to do emergent procedures for this particular patient. And so when I think about an emergent situation, I would think about needle decompression. And if I'm thinking about an urgent situation, I'd probably head straight to a chest tube and I wouldn't do a needle decompression. So I think in this patient, I would look and say this is an urgent case that does require tube thoracoscopy and should have a chest tube placed.
That's great, Christine. And I think kind of a helping branching point to kind of differentiate, urgent versus emergent and when you would do a chest tube versus needle thoracostomy. And, I know a lot of people may not be familiar with having to do an emergent needle decompression, as you mentioned. Would you be able to walk us through that?
Sure. So it's a pretty quick procedure because it's an emergent thing. So basically what you want to get is an angiocath or some form of needle, and you want it to be large enough gauge that you can decompress and let the air out relatively quickly because, again, these are the patients that are in emergent situations. So either they're hypotensive, they're tachycardic, but really tachycardic, and they're not at all stable. You're worried that they are going to code at any moment. That's when you're really going to use your controlled decompression. Also, if you're thinking they're heading in that direction and you don't have a chest tube available or you don't have the expertise to place a chest tube in the next little bit so that you feel that the patient's unsafe, that's when you want to do it. So what you need is an angiocath. Typically, we think about 14 or 16 gauge, but anywhere from 10 to a 16 gauge would work, whether that's a needle or an angiocath. Angiocaths are a little bit better just because they're a little bit longer. And especially in the American population, we think about needing a little bit more needle to get through the chest wall than the average American patient. And so what you would typically do, and I mean, it's emergent, so if you don't have the chlorhexidine or betadine or whatever present, then you can skip that step. But most of us would try to use chlorhexidine or betadine to just, quickly wipe off the area. You're going to go into the second intercostal space in the mid-clavicular line. So to be fair, if the patient is having a tension pneumothorax or they're in extremis and it's an emergency situation, you can pretty much put your needle anywhere. But really, the traditional space would be the second intercostal space in the mid-clavicular line. You want to just clean that area if you can and if you have time, and otherwise just stick that needle in, and you should hear a nice big needle there. Then you're going to leave that in, and meanwhile, get supplies to place a chest tube. So you would never do a needle thoracoscopy or needle decompression and not follow it with a chest tube.
That was going to be a follow-up question I had, Christine. Kind of what do we do after you decompress with the needle? And you answered that for us. So definitely plan on getting a chest tube inserted immediately after. Thank you so much for going through that.
Yeah, oops.
Yeah, and I think that's a really nice tip about the fact that, like, if it's a really a tension pneumo and you've seen on an x-ray it's pushing everything over, I think like the most common question I get is like, where's that second space? But if it's really a tension, I mean, you just get it between a rib, right? Get the air.
But it's a clear lip. And honestly, if you can go laterally, if you feel a little bit more comfortable, then, you don't want to go through breast tissue and, certainly you don't want to hit the part or whatnot. But, so try to go a little bit higher. So the second or third intercostal space is neither of those are going to be problematic. And then you can go laterally if you need to. But the traditional teaching is second.
So luckily, as you said, this patient was urgent, not emergent, and there were providers around. So he was able to get a chest tube placed. So he had the chest tube. There was air that came out initially, and it immediately sort of felt better. So Charlie, going back to you, once you have the chest tube in place, it seems like that sort of urgent situation is solved. But what's going to be the next step for our providers, taking care of a patient who now has their chest tube?
Yeah, important question. I've been in a situation where I had to do an emergent needle decompression, as Christine just described, and you connect the two. I put in the angiocath, and the patient got immediately better, and on the back, and then remembered that the intrapleural space is negative pressure, and as soon as you evacuate enough air that there's no longer tension, that space is going to suck air back in from outside the patient unless you connect whatever tube you have there to something. And that same principle applies with the chest tube. So once you have the tube in place, this is sort of like taking steps back for a lot of people, but I think it's important to kind of remember the logistics of what your chest tube that you have connected to the intrapleural space needs to be connected to in order to like definitively solve your problem. And typically we think of like a chest drainage system, like a Pleurovac, and the Pleurovac has 3 chambers. And the first chamber that in the Pleurovac that connects to the patient is your collection chamber. And that if you have fluid in the space, like for a fusion or, pneumothorax, that's where that fluid is going to get collected. But air also passes through there into the second chamber, which is the water seal chamber. The water seal chamber, just as it sounds, is an area of the drainage device that is full of water or saline. And the idea is that air can get out without getting back in. And a way of thinking about how this works is like if you are drinking through a straw, if you breathe out the straw, you'll see bubbles pass into the whatever you're drinking. But if you suck in through the straw, you're not going to suck air, you're just going to suck fluid. And so the water in the water seal chamber prevents air from getting back into the patient while allowing it to leave. And it's in the water seal chamber that we evaluate for an air leak, which when present indicates that there's still air in the intrapleural space, i.e. the pneumothorax is not resolved. And then the third chamber that's most distal in the chest drainage device or Pleurovac is the suction chamber. And that's where you control whatever suction that you're applying. I think it's also worth noting that most of the time we connect our chest tubes to a Pleurovac or another chest drainage device, but in rare cases, you can connect it to just a Heimlich valve, which is basically, it functions the same way as the water seal chamber without suction, where it allows air out without going back in. So back to our patient, we have a chest tube in place. That tube needs to be connected to something. As I mentioned earlier, I'd connect it to like a chest drainage system, a Pleurovac, probably apply, negative 20 centimeters of water suction to ensure that we are evacuating pneumothorax, while ordering a chest x-ray to ensure that the tube is in place and that the pneumothorax is resolved or improving. Having said all that, I will say there is some variation in guidelines and, talking to different people about whether or not somebody who's relatively stable with pneumothorax needs to go straight to suction or whether it's more appropriate to just start by having them on water seal. My preferred practice is to put them on suction at least until you see an X-ray confirming, that the pneumothorax is improving after the chest tube has been placed. I think it's just a safer option. But
Trev, we were talking about this before, and I think it seems great. You could just go to water seal if they're up, but I also feel like it's also the run of the mill in the hospital. Like you're running around, you're not sure, you don't know who's going to be watching the patient and the next chest X-ray. So I think if you know that they're going to be under good observation, then going not suction. But a lot of times I feel like I just put it on suction, so I feel safe and comfortable that the patient's in a good spot.
yeah, I totally agree.
What I will say is that depending on the size of the pneumothorax, if it's expanding pretty rapidly, some of the patients really have a ton of, and taking the suction off can really help with that. And so if you're really suffering with a lot of pain, taking the suction off as long as the lung doesn't block it, can be pretty. So you may want to take them off suction if that's the scenario. I would really stick to because you want to make sure you're not going to put them in a bad spot again. But that's sort of one of the scenarios where you consider putting the patient on water seals.
Thanks so much, Charlie and Christine. I think that was a great discussion, talking about how to manage and approach a patient with an unstable pneumothorax who required urgent chest tube. I know that's not the only type of pneumothorax though. So fortunately we have another consult coming in. So just as we were getting very settled in, we get another page. So probably like your typical IP pager, I think, going off today, Christine. This is Barry's cousin, Larry. So Larry's a 22-year-old gentleman. He's also presenting with shortness of breath and has some chest pain. Thankfully, though, Larry's more stable. He has a normal heart rate in the 80s. He's normotensive, and he's saturating 96% on room air. And he has no evidence of tachypnea currently. He was breathing 12 to 14 times a minute. He has a chest X-ray that shows what is being read as a small pneumothorax, but you're having trouble pulling the image up. He does say that he has no significant past medical history, has never had a pneumothorax before, but he does smoke 1 pack per day of tobacco and occasionally smokes marijuana. So, Christine, based on what Charlie talked about and told us before, how would you classify this second patient, and what would be your next steps in management?
So the first thing I think about, again, is this patient emergent, urgent, or stable? And I think clearly pointed out that this patient falls into the stable category. Hemodynamically, completely rock solid. You don't have to run or rush everywhere. So with this patient, you certainly have time. So the fact that you can't necessarily see its X-ray right away, or you're told it's small, is reassuring, and you can take some time to gather your evidence and gather your facts. And so the way I then approach these patients is thinking about, as Charlie mentioned earlier, is this a primary or secondary type of pneumothorax? And then the other classification we think about is spontaneous or iatrogenic. And so, and iatrogenic / traumatic, right? So, so primary spontaneous would probably fit this patient the best. Larry is young, and so although he smokes a fair bit, which is certainly a risk factor when you think about pneumothorax, he hasn't probably smoked long enough to have terrible destruction in his lungs, unless he has some underlying lung disease that we haven't discovered based on his history, or that we think if he had some terrible destructive lung disease, whether he has cystic fibrosis or today or some other form of disease that's rare, he would probably know to tell you that. So since he's not telling you that, we can probably assume he probably doesn't have any significant underlying lung that we know about. But certainly smoking is one of those things that would put him at risk. And what kind of risk is that? I mean, smoking gives you a 12% lifetime risk increase in developing pneumothorax. So,
Wow.
and it's really dose related. So depending on how much you smoke, that could predispose you more or less. So if you have a light smoking history, you have a 7 times higher risk than most people developing pneumothorax. If you have a moderate smoking history, if you're a heavy smoker, so more, you think about 102 times higher risk than the normal average person to develop pneumothorax. So smoking is a really big risk factor that you think about in him. And even though he hasn't been necessarily diagnosed with it, he's somebody that you think about, sort of working up at some point to look for some small blebs and things that are probably, but just on the surface, if you're seeing this patient, you probably classify him as a primary spontaneous pneumothorax. So no significant underlying lung disease, spontaneously developed. There was no trauma, no procedures, nothing else happened. So he would fall into that primary spontaneous pneumothorax.
Thanks, Christine. Yeah, I was not aware of the kind of the dose dependence and the 12% risk of increase of pneumothorax with smoking history. So thank you for pointing that out. And I do want to ask you a follow-up question. Since we're thinking that this is a first episode of primary spontaneous pneumothorax, is it common then to kind of do further workup or evaluation for a patient like this? If you're concerned about underlying lung disease, I guess what would be some things that you would consider?
Like, and follow up with Monty, I feel like that question comes up like a lot for like non-smoker. If it's a man or a woman, they come in with a new pneumo, like what do we do after?
So you want to think about how often will primary spontaneous pneumothorax recur? And it's 25 to 50% recurrence rate, usually within the first year. And so typically, what we do is think about if they do have any risk factors like smoking, as in this gentleman, then you may want to consider a CAT scan and try and see if you can identify blebs or anything else that would have predisposed this patient to a pneumothorax. Um, Other people don't necessarily do an extensive workup for primary spontaneous pneumothorax. You can fix it and then try and decide, does this patient require anything further? And if the history and the imaging doesn't suggest much else, we tend to leave it at sort of imaging and then follow them up in clinic. And typically, and I would always follow your patients up in clinic. So have them, follow up, short-term follow-up, so the to test X-rays, make sure the thorax hasn't reaccumulated. And then if everything is fine, they can either follow up as needed. So if they ever have symptoms again, or if you're being a little bit more conservative or cautious, you can say follow up in 6 months or a year, and just with another X-ray and just make sure that everything's been good. That everything is nice and stable with these folks. And then you also have to think about pneumothorax, and so also talk to them about, is this the period of time that they're having their menstrual cycle? Within a few days of that, it's not as uncommon as we think, and uh, so it does come up a fair bit. I see generally like 3 to 5 patients like that in a year or two. So it's certainly not completely uncommon to see that. So you do want to sort of ask questions about
Wow. Yeah, catamenial pneumothorax is going to be on my list of diagnoses that
that.
to consider to make one day before I'm done. Okay, this is great. So it sounds like we have a 22-year-old man, no past medical history except for some smoking, and then we've sort of all said primary spontaneous pneumothorax is clinically stable. We finally pull the chest X-ray up and we take a look, and it is small. It's at 2.5 centimeters from the apex, and we've talked about that before. That we put him in the small category. The team is consulting you, said pneumothorax, and they're asking for a chest tube. So Charlie, what are you going to do for this patient?
I hate to disappoint our primary team's consulting us, but I think this guy, I forget if it was Larry or Barry, Barry, is probably best without a chest tube. Like our first patient, who's hypoxemic, tachypneic, tachycardic with a large pneumothorax, this guy, he's clinically stable with a pneumothorax that's less than 3 centimeters. So I think we can feel confident that he's going to do okay without a chest tube or a needle to drain the air. And in fact, doing so might cause more harm than good. We can, consider applying supplemental oxygen to help resorb the pneumothorax more quickly. Some lung trivia that I recently learned is that the way this works is actually by creating a nitrogen gradient. 100% of FiO2 increases the partial pressure of oxygen in the alveolus, which decreases the nitrogen partial pressure, and that causes a nitrogen gradient between the alveolus and the pleura that leads to air moving in. Can help resorb things more quickly. But yeah, other than some oxygen and then repeating an X-ray, after some hours of observation, I think that is like how I would limit my intervention on Larry. And sadly, I don't think we get to place a tube.
I
Yeah.
can't
Yeah.
believe you
Never.
just took away the pimping question of like every pulmonary doctor. Rounds are forever ruined. Pneumothorax.
Nitrogen growth.
All the
It's always
nitrogen
the
fans out there that are pleased because I feel like we don't talk about
Yeah.
nitrogen content too much in the air that we breathe.
That's great. And then just a quick follow, for both of you, just because this always comes up on the practical end of things. One, I feel like we say, 100% oxygen. And then I've gotten the page a bunch of times be like, okay, what does their O2 setup to be? Should they be on high flow? Do they need BiPAP even? I've been asked for before. And then where do they need to go? Do they have to be in the step down unit or ICU because they need 100% oxygen, or where we manage these patients? So those practicalities, okay, if you could comment on, would be great.
I think 100% of FiO2 is helpful. And the reason why is it just increases your rate of absorption. So for all the reasons that Charlie just demystified for everybody, 100% of FiO2 actually really helps. It's still slow. It's so slow to reabsorb, but it definitely helps. Where your patient has to go, whether they need to go in a step down or an ICU, is really going to be dependent on your institution.
Yeah, I totally agree. I think you want to give 100% FiO2. I have seen the mistake where non-invasive, like BiPAP, was placed, which is not a good idea in somebody with a pneumothorax, like applying positive pressure to the system that can, worsen the pneumothorax. I think just like a simple 100% non-rebreather mask should be fine. It's low pressure and 100% FiO2. And then, yeah, it kind of depends on where the sort of medical or hospital you're operating at. And some patients, might require admission. This guy who's, pretty young, no other medical problems, you might even be able to discharge them from the emergency room after, hours of observation if like follow-up x-rays reveal no worsening of the pneumothorax and you think you have like a reliable close follow-up.
Thank you both for walking us through that. This patient was placed on 100% non-rebreather, as you mentioned, Charlie. He was admitted to medicine for 24-hour observation. The pneumothorax remained stable. He did get an X-ray the following morning. He continued to feel well overall and was discharged to follow up in clinic. He was advised about the risk of smoking and given information about Chantix. Christine, I want to ask you though at this time. I know in our first case you did talk about in an emergent situation, doing needle decompression, specifically if there's tension physiology. But want to change the scenario a little bit and say for this current patient who was stable, but if he had a large pneumothorax on X-ray but was overall hemodynamically stable, would that change your thinking at all? And would you ever consider catheter aspiration, or can you talk a little bit about that for our listeners?
Yeah. So I think if you have a large pneumothorax, which again, we think about as anything more than 3 centimeters from the apex of the lung or 2 centimeters from the hilum of the lung, which sort of indicates about a 50% chest volume size. To put that sort of into context, it's hard to sort of judge your volume when the lung's collapsing. But with a large pneumothorax, the chance of that sort of re-expanding on its own and everything else is so much lower. So you definitely want to intervene and either place a chest tube, or you can, like you were saying, you can do a catheter aspiration or a needle aspiration. In the US, we tend to prefer tube thoracostomy versus the aspiration. However, our colleagues in Europe really do quite a fair bit of aspiration. And honestly, their patients tend to do well. We feel like the chest tubes really do tend to evacuate the pleural space a little better if you're manually aspirating air. And it's a little bit hard to quantify, but they're saying that if you evacuate, let's say 2.5 liters of air, that chance that you're going to properly evacuate your pneumothorax is pretty slim. So in that case, once you get to about 2.5 liters, you're thinking you have probably a persistent leak and you're going to need a chest tube. But you can absolutely, and I have done it sometimes. Let's say you have use a thoracentesis kit, you can use angio catheter and just start taking the air out with a syringe. and just manually testing that pneumothorax. You can certainly do it. Here, we worry a lot about our patients going home, and then their pneumothorax reaccumulating, and they're not here for you to intervene if anything goes wrong. I think also, thinking in the bigger context of healthcare, right? ER visits, the time it takes, the money it costs for patients to come back and forth, may be prohibitive. And so we're really trying to make sure that we sort of take care of this pneumothorax. But it certainly works. And like I said, in Europe, they've been quite successful doing the manual aspiration of these. The risk is really just that it's just, you may not fully evacuate the pneumothorax. And
Thanks for going over. And I feel like I always see those trials, and then and you said it so well. It's like it all depends on the context and who your patients are and what resources you have. So it's great to hear your opinion on it. All right, man, busy day. So we have another patient who's coming in. Larry and Barry are all set, but this time we have a page from a medicine floor for Carrie, a 54-year-old woman who has been admitted with a COPD exacerbation. She has emphysema. She's not on home oxygen. She came in 2 days ago with worsening shortness of breath and an increased productive cough. She's been treated with nebulizers. She's on azithromycin and steroids, and she's been on supplemental O2 while she's been in the hospital, but she never needed to be intubated or BiPAP or anything. This morning, she had a coughing spell and significant chest pain, and then a chest x-ray was obtained afterwards, given the complaint that she had, and she has a moderate-sized left-sided pneumothorax. She's now on 10 liters, and she's tachypneic to 26. She's been mildly tachypneic throughout her stay. The heart rate is 105, and her blood pressure is unchanged since. So, Charlie, you walked us through your initial approach to patient with a pneumothorax before, and you said those 4 different categories are to evaluate the patient. So how would you evaluate this patient and apply some of those principles?
I talked earlier about the distinction between primary and secondary spontaneous pneumothoraces, and this is like a, classic example of a secondary spontaneous pneumothorax from somebody who's got, significant underlying emphysema. This, I liked Christine's earlier breakdown of urgent versus emergent versus no need for chest tubes when it comes to patients with pneumothorax. And I would say that this lady needs a chest tube urgently. She's significantly hypoxemic on 10 liters. She's tachypneic. She's tachycardic, although her blood pressure is okay. But patients, like I said earlier, with underlying lung disease like Carrie, they just have less cardiopulmonary reserve. And so can't deal with a pneumothorax that has not been controlled with the tube or drainage for long unless it's like very small. So I would plan on placing a chest tube in this patient.
Thanks, Charlie, for walking us through that. I think that's important point that you brought up. Just people with underlying lung disease and just they may have a more limited cardiopulmonary reserve, such as our patient. So she does end up getting a bedside pigtail catheter, and the chest tube is placed to a -20 suction, like you mentioned before, Charlie. Christine, I do want to ask you though. Charlie mentioned that this is a secondary thorax, and since you've cared for so many people with pneumothoraces in the past, what are some other common predisposing conditions that our listeners should be aware of?
so by far and away, the most common is sleep, for sure. So that's probably correlates with, you know, probably half or even more of the patients that get pneumothoraces have some degree of emphysema or and it really correlates with the severity of the disease. The more severe the COPD or emphysema, the more likely to develop thorax. Other things to think about, so interstitial lung disease, and you definitely get pneumothorax. Cystic fibrosis, they have sort of a 3 to 4% overall risk of pneumothorax, and that increases with age. So now that we have better treatment options for these patients, if they live to be 80 years old, almost 20% of them will have experienced pneumothorax. So that's another sort of key population that we see quite a bit. But any sort of cystic lung disease, today, gland, all of the underlying lung diseases will certainly predispose. Anemia, if so, if you have endometriosis, women, a lot of those patients will end up with and so we see it. So it's a pretty wide swath of patients that we can that we can see pneumothorax in. And again, don't forget your smoke, even if they don't have overt lung disease on CAT scans. Um, they often have little subpleural blebs that can rupture. So that's why the smoking test is so.
All right. So we've had a busy day. We've had now 2 patients who've had chest tubes placed and a third that was managed conservatively. And both these patients now have their chest tubes to suction. And we've sort of talked about this in passing. We've talked about patients not needing chest tubes sometimes we have to do drainage, but most often these patients will end up with a chest tube. And then we've mentioned a couple times words like air leak and things like that. But I want to be sort of explicit about it now. So Charlie, if you're following these patients, let's start with our first one, Barry. He was our patient who had a primary spontaneous pneumo, but was a little unstable, so he got a tube. What is the process for managing these chest tubes and specifically, and then for weaning them off and eventually pulling the chest tube out?
Earlier, I mentioned there's kind of three components to your standard chest drainage system or pleurovac. There's a collection chamber, a water seal chamber, and then a suction chamber. And then similarly, there's kind of like three different settings, if you will, that you can have a chest tube set up at. So you can have a chest tube set to suction, and usually that's where we start with our patients who have a pneumothorax, where we connect a wall suction or some other portable suction device to the chest drainage system, and then we can modulate the suction usually to -20, which is more negative than what your normal intrapleural pressure is. And what you want to be looking for is whether there's air still passing through the chest drainage system, and we check for that by looking in the water seal chamber for bubbles. And if there are bubbles present, then they have what's called an air leak, which means that there's still air in the intrapleural space, and therefore the pneumothorax is still present. Another thing we're looking for is like as we kind of evaluate next steps is like what does the X-ray look like? So now that we have the tube in place and the suction is going, does the pneumothorax look improved or resolved? Once you have somebody on suction and you see that there's no longer an air leak and the pneumothorax is resolved, then you can consider putting them to water seal, which means you basically just take them off suction, but the tube is still open. And so there's still, a system in place through which the air in the intrapleural space from the pneumothorax can be evacuated through the chest drainage system. And if there's still air to be drained off suction, then they will have an air leak. So you're evaluating the water seal chamber for an air leak, and then when they're on just quote water seal but off suction, you're also checking X-rays to see if the pneumothorax remains resolved off suction. Once you feel confident that the pneumothorax is resolved on the water seal setting, and think you're close to being ready to remove the tube, what you can do what's called a clamping trial, where you literally just clamp the tube. Um, between the drainage system and the patient. And so you're definitely not going to see an air leak anymore because the clamp is preventing air from passing into the chest drainage system. But what you want to do is after clamping, check an X-ray and see if the pneumothorax has recurred. And if it has not, after a certain amount of time, and this sort of depends on where you're practicing and who's doing it, but if the pneumothorax is resolved and the tube has been clamped for some time, you can feel confident pulling the tube, and you feel confident that the pneumothorax is not going to recur. I think, as I mentioned, there's some variability in how much time to spend in each step. I typically, it depends on how sick the patient is and, how large the pneumothorax was in the beginning and how fast that they're kind of progressing through each step. But at a minimum, I would say I usually like to have a patient on suction for hours after I place the chest tube. And then if it resolves and they seem to be low risk, then I'll switch them to water seal. And I'd like to watch them for at least a day in water seal. And then if they're still progressing at that point, and it seems like the pneumothorax is resolved, then I'll clamp it and then, repeat an X-ray after it's been clamped for, a few hours. And then if it's resolved, I'll pull the tube. But, some people don't clamp at all. Some people want it clamped for 24 hours. There's a lot of variability in the timing of each step. But I think the sequential approach is the most support with the tube involves suction, and then water seal means the tube is open, but you're not adding extra suction. And then clamped means the tube is in place, but you're not draining anything through it. And those are the kind of the sequential steps to take when you have a chest tube in place for pneumonia.
I agree with that. The timing, so funny. Like everybody wants a specific how long should we put them on water seal? How long do we put them on therapy trial? But it's really dependent on how big the thorax was, how significant was it to their hemodynamics. So how stable or unstable were they with that? And what is their under? That is all going to factor in to how long you're going to keep these patients at each sort of subsequent step.
Right. I feel like that good rule of thumb in medicine comes in. It's like, if you're not sure, then and probably it's worth asking somebody, and then you just have to put it together.
And I think we all know that, right? The people taking care of these things, we all know there's no set rule, there's no set guideline. So those are calls that it really doesn't bother us at all to get those, to say, how long are we expecting to do this trial? What are we looking for? What sort of hoops does this patient have to get through before going to the next step? That's pretty common, and we don't mind that at all because there's really no good step for it.
Thanks so much, Charlie and Christine, for going through that. And I think most times, I think we can kind of, situations that go smoothly where we can sequentially go through those 3 stages that you mentioned, Charlie. But Christine, probably a little bit more of a loaded question for you. And I know it'll depend as well. But, what options do you consider for a patient who either has a persistent air leak or whose lungs are not fully re-expanding despite having a chest tube?
Yeah, good question. That is where it gets really tricky, right? So persistent air leak, we think about as for 5 days where they're still leaking air through the tube. And so I sort of go through my list. So we start with conservative management. So supplemental oxygen, chest tube, Heimlich valves can be used. They're really more outpatient than inpatient, but they can be used usually as an inpatient. We attach them to a collection device that Charlie's sort of gone through with us. And you can use other things. So if you think a patient has a persistent air leak, so it's been 5 days, nothing's still resolving, you can do a blood patch where you take some of the patient's own blood and will inject it through the chest tube, and hopefully that will seal up. You can consider chemical pleuresis. With that, you have to just consider, again, who's your patient? How well are they going to tolerate the pleuresis? And is that pleuresis going to get in the way of any future plans for this patient? So if that patient would need chest surgery in the future, or if they're ever going to be considered for a lung transplant, you want to think maybe avoid chemical or talc pleuresis for those patients. And then there are a lot of sort of things that are not very common to use, but you can use different fluids or tissue expanders, foams, plugs. We do use endobronchial valves also for persistent air leaks. So that would be an off-label use. Typically, those are approved if the patient is post-surgical. So if they've had an anatomic resection of sorts, a lobectomy, etc., or they've had lung volume reduction surgery, and they have persistent air leaks, then the valves would be considered on-label. But I would say more than 90% of the valves that we place for persistent air leaks are off-label. So it's for all of these kind of patients that have COPD or underlying lung disease that end up with a pneumothorax that doesn't quite resolve. And if it's been days that they're in the hospital, it's not resolving, you can consider placing these valves. They end up staying in place for 6 weeks. And ideally at that point, the leak should be fixed or resolved, and then we can the valve after that. If none of those things work, you can think about surgical options with that, so they can look for the different bloods and take care of those, and they can do either chemical or mechanical pleuresis as well.
Thanks, Christine. And one thing I want to have you just weigh in a little bit more, because I remember as a clinical fellow, I did have a patient actually who was diagnosed with LAM, who had pneumothorax requiring chest tube with a persistent air leak. And as you mentioned, we avoided pleuresis in her just because she was being considered for a lung transplant.
Yeah.
But we did have a very kind of lengthy discussion at that time, and there were a lot of people kind of weighing in on, should she get the Heimlich valve or not? But I know some people may not be familiar with what a Heimlich valve is, or kind of, if the patient has that outpatient follow up, what does that look like?
Yeah. So Charlie mentioned it a little bit earlier as well. Really, the Heimlich valve is essentially a one-way valve. So it lets air to come out of the chest, doesn't allow extra air to go back in. So it's just attached to the very end of the chest tube that's outside of the patient. And again, it's just going to allow air to slowly but surely escape out of the chest without allowing any pneumothorax to sort of reaccumulate and it's not through that chest tube. And that sort of slow drainage allows the visceral tear to heal. You don't require, your patient has to be somewhat stable in order to put a Heimlich valve on. So if they're requiring continuous suction, that's not a good patient for a Heimlich valve. Your patient has to be able to tolerate essentially water seal. So if they don't need continuous suction, if they are relatively stable on water seal, and the pneumothorax also doesn't have to be completely expanded. I think that's something else that's really important for people to remember and consider is that a pneumothorax might be 90% of the way fully expanded and resolved, but there might still be a small pneumothorax that remains. And that just is going to take time to absorb and resolve. And that's okay as long as the patient is clinically stable. So I don't mind if there's a little bit of a residual the lung doesn't have to be fully expanded. But if they can tolerate water seal and are stable, not requiring oxygen, are able to ambulate the other things, then we can put a Heimlich valve on their chest tube and they can go home. If they are going to go home with a chest tube, you really want very close follow up. And so I typically see those patients on a weekly basis. Um, and you just want to really go through with them. You have to pick the right patient because they're going to go home with a chest tube that's not meant for long term use, that's typically used only in a hospital setting. So they have to be able to keep it clean, keep it dressed appropriately. And if you're sending somebody home with a pneumothorax and a chest tube, they have to know the warning signs. They have to have somebody around them that's going to be able to bring them back to the hospital, urgently if needed. But hopefully, most of these patients, by the time you would consider discharging them home with a Heimlich valve, would be stable enough that they could tolerate a little bit of a reaccumulation of a pneumothorax, be able to recognize it, and come back into the hospital. The other thing that's probably a little bit more common than the Heimlich valve, but is the same idea, is called a pneumostat. And it's just a really small collection chamber that again attaches to the end of your chest tube. Your patient, there's like a little well that you can put a few drops of saline or sterile water, and it can check for an air leak. So your patient can actually check if there's bubbling when they put the saline or sterile water into the well. If it bubbles, then there's still an air leak present. Um, but it's just a little container that attaches to the chest tube. So if there's a little bit of pleural fluid that comes out, it doesn't leak onto them or onto their clothing. They can drain it if they're there, and it just kind of sits again like just underneath their clothing, stuff like that. So that's probably used a little bit more commonly than the Heimlich valve because the Heimlich valve again will leak pleural fluid and all that stuff gets dislodged a little bit easier than the pneumostat. So that's something that we also use for outpatients.
Interesting. That's a great review of the definitive management and then sort of the prolonged management we can do for these patients and when we kind of consider them. So to wrap things up, Charlie, I want to go back to you. We sort of talked about this plan that we were doing for Barry, and he had having his lung fully re-expanded, the air leak resolved, his chest tube was clamped, no reaccumulation, it was removed. Thinking about Carrie, this was the patient with COPD and a secondary spontaneous pneumothorax. We just heard from Christine all of the things for definitive management, and we talked about the process that we normally go through for a chest tube. So any other considerations if it's a secondary spontaneous? Do you just go through the same process or is there a different algorithm?
Yeah, I'd say the kind of the sequence of suction to water seal to clamping is the same. You might be more careful and take kind of more time each step. And somebody like Carrie, who's got less reserve than Barry, who was like young and healthy with just a large spontaneous pneumo. So I think it's more of an art than a science. How much time you spend in each step, and then once you have control of the pneumothorax, patients who have like significant underlying lung disease have a higher risk of recurrence of their pneumothorax because like the underlying problem that predisposed them to it is not gone after you deal with the pneumo with the chest tube. And so, in addition to like, maybe slightly more careful management of the chest tube that you placed, you might be more likely to refer a patient with a secondary pneumothorax who's got significant lung disease for a definitive management with some of the things that Christine was talking about.
Well, this has been an incredible discussion. I really want to thank you both so much, Christine and Charlie, for walking us through all of this. I think it's going to be very helpful for the listeners. I know it's interesting for me. We like to wrap up with each of those just a takeaway point. So we'll just kind of go around. Mine is kind of what you were just saying there, Charlie. It's we have these algorithms, placing it, suction, water seal, clamping. Sometimes you can do a drainage, sometimes you do a chest tube, but most important thing is looking at the clinical status and the underlying lung disease and reserve patient. And we're going to sort of adjust all of these based on who that patient is and how they look. Time. Monty, what about you?
Yeah, kind of Christine's point on the risk of pneumothorax occurrence with tobacco is really resonating with me. So that was definitely a learning point for me. And thanks for bringing that up, Christine.
And Christine, one takeaway point for our listeners?
I would say just my approach has always been, to don't panic, kind of come into your situation and start categorizing your patients. So urgent, emergent, or stable, and then primary or secondary, and start thinking about that because that's going to affect your full approach. So if you can just start with a quick categorization rather than panic, everything will go much better.
Great. Always good advice. Charlie, to wrap us up.
Wow. Yeah, you guys covered it. I think we'd be remiss if we didn't mention lung ultrasound at all. So if, say, somebody like Carrie, who's already in the hospital, you suspect a pneumo, you're waiting on the x-ray, you can put a probe on them. The sensitivity and specificity of lung ultrasound when, trying to diagnose a rule out pneumothorax is really good. You're going to look for absence of lung sliding, the absence of lung pulse, the presence of lung points, or barcode sign on M mode. These are all, in 30 seconds, like the ultrasound findings of a pneumothorax. So, if you're waiting on an x-ray and you're really worried, put a probe on.
Amazing.
Can I add one more point?
Please. Yeah, you got 10
Can I get a bonus point? I like that, a bonus point. So the other quick thing that comes up a lot in clinic with our pneumothorax patients are about subsequent air travel. So you want to think about your pneumothorax needs to be resolved, like fully resolved, for at least 1 week before you travel by airplane. And then the other situation that comes up is scuba diving. So unless you've had definitive management for a pneumothorax, if you've ever had one, you should definitely never, ever go scuba diving.
That's great. Those are gonna be like the most important things that we talk about. I love it. All right. Well, this episode was written, produced, and edited by myself and Christina Montemayor, and the music is original music by Eric Rogers. And we will see you next time.